right. I'm happy to. I have something. If you'd rather just get up and start talking, we can certainly do that as well. Okay. Good morning. Good morning. Can you all hear me back there? All right. Well, welcome to Grand Rounds this morning. We have with us Dr. Gary Rosenthal. Many of y'all know him. I think he's somebody that goes without having to have an introduction, and I think that speaks to how personally invested he is into his role as the Tinsley R. Harrison Professor and Chair in the Department of Internal Medicine here at Wake Forest and the Physician-in-Chief of Wake Forest Baptist Health. So I knew a lot about Dr. Rosenthal, but looking through his resume, I learned quite a bit more. He has been a national leader in internal medicine in this emerging field of research of learning health system science. Over the past 25 years, in fact, his research is focused on really kind of three related areas: development and implementation of innovative strategies to improve hospital care and chronic disease management. He's also focused on development of metrics for measuring the quality of care and provider performance, and this idea of development of multi-institutional data networks to identify variations in healthcare delivery and to support practice-based pragmatic trials. He's worked hard to pioneer novel approaches in quality measurement, including a program to evaluate hospital quality on a regional level, Cleveland Health Quality Choice, that still serves as a national model for a value-based healthcare purchasing of healthcare services. Furthermore, prior to his recruitment here to Wake Forest in 2016, Dr. Rosenthal was the director of the University of Iowa Institute for Clinical and Translational Science and the VISN 23 PACT, or PACT, demonstration lab at the Iowa City VA Medical Center. He served as the director of the Division of General Internal Medicine at the University of Iowa and the founding director for the Center of Comprehensive Access and Delivery Research. And Dr. Rosenthal is the author of over 180 interdisciplinary peer-reviewed manuscripts. He's received external funding from multiple sources, including the VA, NIH, PCORI, AHRQ, HRSA, Robert Wood Johnson Foundation, Commonwealth Fund, Donald Reynolds Foundation, and the Center for Medicare and Medicaid Innovation. On a national level, Dr. Rosenthal is a former president of the Society of General Internal Medicine, which he served from 2010 to 2011, and the Association of Chiefs and Leaders of General Internal Medicine from 2005 to 2006. He's currently on the board of directors and executive committee of the Association for Clinical and Translational Science. He received his undergraduate degree from Johns Hopkins, his medical degree from the University of Pennsylvania, and completed his residency in internal medicine and fellowships in general internal medicine and geriatrics at the University Hospitals of Cleveland and Case Western Reserve University. So, without further ado, let's please welcome Dr. Rosenthal. Great.
So, thank you. I really wanted to thank everyone for coming this morning. This month marks the start of my, fourth year at Wake Forest, and I can't tell you how much I've enjoyed the privilege of serving as chair, and just incredible opportunity to work with so many talented faculty, house staff, and staff. And I think, the past 3 years have really represented, sort of an ultimate dream job and just an incredible opportunity professionally and personally. What I wanted to do this morning, as I've done the past couple of years, is to give you an update, on the Department of Internal Medicine and, where we stand. And I wanted to highlight a lot of our accomplishments, collectively, as well as review some of the individual accomplishments of faculty, and house staff. And I will say, so the mea culpa is that it is impossible in 45 minutes or so to capture all of the amazing things that go on in the department. So what you're seeing is really just the very abbreviated Cliff Notes version of the department. In addition to sort of highlighting our accomplishments, I wanted to talk a bit about some of the challenges that we face. And many of these challenges are challenges that are endemic in healthcare today and in medicine. But also, every challenge we face represents an amazing opportunity. And so I wanted to also talk about those as well. So there we go. So the subtext for my presentation this morning is thriving in the midst of VUCA. And I realize that, so VUCA is probably a term, that's foreign to you, but I think it captures what many physicians and healthcare leaders sense about, healthcare today. So VUCA, stands for volatility, uncertainty, complexity, and ambiguity. And it was a term that was developed, by the U.S. Army after the fall of the Soviet Union and the opening up of the Iron Curtain, in which all of a sudden, the U.S. didn't face a single major adversary, that was a nation state. And in its place, often, the major challenges, facing the U.S. government were sort of organizations and ideologies, and not, individual nation states. And it was an environment that, in many ways, was much more difficult, to navigate. And when we look at healthcare today, as a sector of the economy, many economists feel that healthcare is one of the most VUCA, intensive sectors of the economy. And so when we look at healthcare, what do we see? We see just an incredible amount of changes. We see mergers and acquisitions, so we can only, look at ourselves and, look at Lexington, Wilkes, the construction of Davie, our recent, acquisition of High Point, and then, I think the big VUCA event that's out there, our looming partnership with, with Atrium. We also see, changes in our reimbursement models, declines in our reimbursement models. Many of our reimbursement models now are predicated on our ability, to contain costs and maintain quality. And if we don't do that, we're at financial risk. So, this environment we face, is really full of, volatility, uncertainty, complexity, and ambiguity. But I think, as a sort of prelude, to this presentation, the major message that I'd like to leave everyone, here with is that each of these challenges, represents an amazing opportunity, an opportunity to use our creativity and think about how we can develop better, delivery models that lower costs, that improve quality, and that, provide, more value. How we can use, our passion to develop, better delivery systems. And I think it's that energy that I would really like us as a department, to tap into, and think about on a daily basis what we can do, to really create, a much brighter future and a much better, healthcare delivery system, for us and our patients. So with that as a bit of an introduction, I wanted to start things off with faculty promotions in 2019. And as probably everyone knows academic promotions represent one of the most significant occurrences, because to get promoted, indicates that someone has really had a sustained track record of accomplishment and has made very significant accomplishments. And this past year, we had 6 faculty who were promoted to associate professor or who received, tenure. Prashant Bhavi from cardiology, Candice McNeil from ID, S.K. Das from molecular medicine, Lee Jun Ma from nephrology, Tao Ma from gerontology. And in addition to being promoted, Tao was awarded tenure, and Alan Sang. And Alan had previously been promoted but was awarded tenure this past year. And we had 2 faculty who were, promoted to professor, Raj Chatterjee from pulmonary and Chris Thomas from, from HEMONC. So, an amazing accomplishment. I think, that deserves another, round of applause, because it's... So what I wanted to do now is really, very quickly kind of run through some of our, major accomplishments across the our 3 core missions. And I'll start with research. And the next slide, I think, is just absolutely incredible. So this slide shows research funding in the Department of Internal Medicine over the past 5 years. And as you can see, our funding more than doubled, from $30.7 million in FY15, to $64.5, million the past, fiscal year. And while, the numbers are impressive, I think it, indicates, a number of factors. And I think this slide, is a really good indication and marker, of the health of the department. So I think it reflects a lot of the investments that the institution has made, in the department. The number of new recruits that we've had have done phenomenally well. Faculty who have been here, have been incredibly productive. And I think it also just highlights, the absolute, quality of faculty in the department. This next slide just shows, breaks things down over the past couple of years. It shows that the increase that we had over the past year occurred both. We had increases in our industry-funded trials. We had increases in our federal funding, which is largely NIH, from $41 million to $43 million, as well as increases in funding from foundations and other sources. So a very balanced picture of funding. So collectively, this is an amazing goal. But I think it also, a large part of our success is, the incredible accomplishments of, some individual faculty. So this shows that we had 15 faculty in the past year with $1 million or more, in, research funding. As you can see, many of those faculty are, in gerontology, which has, had some, absolutely fantastic growth. So Steve Krzyzewski, Laura Baker, Suzanne Kraft, Tim Hughes, Glenn Lesser from HEMONC, David Harrington, Amy Wilkin, Delane Kitzman, Jingzong Ding, Denise Houston, Leah Woods, Tao Ma, Clark Files, Victor Ortega, and Barb, Nicholas. This is really extraordinary, and I think it just attests to how hard these guys work and how talented they are. And, the other aspect of, their research is that they're also amazing mentors. And, they are very active in nurturing, the next generation, of researchers in the department. We also enjoyed incredible success with respect to the School of Medicine Research Awards, which there'll be a formal ceremony for this later this fall. Dave Miller was a double winner. So Dave is a recipient of the first Academic Learning Health System Science Award, as well as He was a member of the team that received the Team Science Award. Bharti Upadhyay received the Clinical Investigator Award. And then we totally cleaned up in the clinical and population science category. Suzanne received the Established Investigator Award. Victor received the Mid-Career Award, and Christina Jugendschmidt the Early Career Award. And Jeff Petty and Christina Bellinger were also important parts of the Team Science Award. So really, amazing accomplishments and amazing people. This also shows, the department is really integral to the research success of the entire institution. And I think one of the really successful models, at Wake Forest is the center concept, in which much of our developmental resources are put into areas of, significance and focus. And here, this just, shows the department faculty who play, leadership roles in the centers of excellence. Jeff Williamson, who actually plays double duty with a co-director of the Aging and Alzheimer's Prevention Center with Steve Krzyzewski and Suzanne Kraft. Jeff also directs the new Center for Healthcare Innovation. Don McLean, who also serves double duty. Don is director of the Clinical and Translational Science Institute and our Diabetes, Obesity, Metabolism Center. Christina Ferdui, who co-directs the Redox Biology and Medicine Center. David Harrington with Cardiovascular Sciences. Bayard Powell is the Clinical Research Director in the Cancer Center, and Michael Olivier, who directs the Precision Medicine Center. So aside from, the grants and aside, from these leadership, activities, I think one of the aspects of the department's research is that it really has, clinical impact and significant implications for changing practice. And again, what I want to do is I'll highlight, 4 publications by department faculty, over the past year that I think have had enormous impact. But, again, this is just a very, minute sampling of a lot of the great, publications, that we had. So the first study was a study that reported the results of Sprint Mind. That this study was led by Jeff Williamson. That looked at in about 9,500 patients the impact of intensive blood pressure control on the occurrence of dementia and cognitive decline. And as everybody knows, the results of Sprint were originally published about 4 years ago, which showed that aiming for a systolic blood pressure target of 120 as compared to 140 led to about a 20% lower risk of cardiovascular events. But this study showed that treating to a systolic blood pressure goal of less than 120 compared to less than 140 significantly reduced the risk of mild cognitive impairment and the combined rate of cognitive impairment or probable, dementia. So incredibly important results, and one of the very first studies that shows that maybe cognitive decline and dementia, are preventable. The second study I'll highlight was also a study that also originated from Sprint. Was a study that Bharti Upadhyay was the first author on. Mike Rocco and Delane Kitzman also contributed, and Delane was the senior author and senior investigator on this project. This was a study published in Hypertension that entitled Effective Intensive Blood Pressure Reduction and Left Ventricular Mass Structure Function and Fibrosis in the Sprint Heart Trial. And this study involved doing very detailed MRI and cardiac function measurements in about 300 participants in Sprint. And I think the backdrop for this study is that we know that from an observational standpoint, left ventricular mass is a very strong predictor of cardiovascular outcomes. However, we don't know what the impact of treating, hypertension and LV mass reduction is on, patients' ultimate, outcomes. And what this study showed was that there was no significant association between the reduced cardiovascular events that was associated with intensive blood pressure control and changes in LV mass or other cardiac measures. And it suggests that perhaps there's other parameters of cardiac function that may be, much more sensitive to aggressive blood pressure control in terms of explaining the better cardiac outcomes. This was a important paper published in the American Journal of Kidney Disease. The senior author of this paper was Mike Rocco, and this paper represented sort of a report and set of recommendations from a committee, the National Kidney Foundation Kidney Disease Outcomes and Quality Initiative, and this is a group within the National Kidney Foundation that Mike leads. And this study looked at barriers and possible facilitators of increasing, the availability of home dialysis. And I think, as many of us recognize, home dialysis, whether it's home hemodialysis or more commonly peritoneal dialysis, is really, underutilized. And this report found that the facilitation of home dialysis will require really a systematic change in chronic kidney disease education and dialysis therapy initiation, the creation of additional incentives for performing home dialysis, and breakthroughs to simplify the performance of home dialysis, modalities. And I think you look at this report, and Barry, I think what this says is, there's probably 5 or 6 grants that could be written, to address a lot of these, barriers. So this is a very important and influential report. The last, study I'll highlight was a study that was published in the Journals of Gerontology that looked at the effect of caloric restriction on cardiac fitness, fatigue, and disability responses to aerobic exercise in older adults with obesity. This was a randomized controlled trial. And what the study found was combining aerobic exercise with even, very moderate caloric restriction was more effective for improving cardiorespiratory fitness, fatigue, and disability and glucose control than exercise alone, and was equally effective, as higher dose, caloric restriction. So I think this study really helped provide insights into, the relationship, between diet and exercise and improving outcomes. And I think gets at a, big issue, with exercise is, what's the dose, of exercise that's really needed? What's the dose of, caloric restriction that's needed? So, very important study. So I wanted to, switch gears and talk a little bit about, some of the key accomplishments in our, education programs. So I just, again, highlighted some, key accomplishments. So want to, congratulate all of last year's third-year residents that are, actually this would be 2 years before. So 100% of the class of 2018, passed the internal medicine, board exam. That is a fantastic accomplishment. This is the second year in a row that we had a rate of 100%. We had rates of about, 85% for a while. And this is something that, we are enormously proud of our, our residents. Especially, so third-year residents in the audience, the pressure's on. One of the other, major accomplishments is that I think we had an incredibly successful implementation of the implementing the X+Y schedule for interns. So as many of you know, this is a structure where, the interns do 3 concerted weeks of inpatient medicine and then a week of outpatient medicine. And the goals really were to improve ambulatory education, improve inpatient continuity, and also to provide longitudinal outpatient subspecialty, training. So I think it's been, incredibly successful. As I was last year, in terms of going out to, about every couple of weeks, I go out to dinner with about 10 of our residents, and what really struck me last year was how happy, the interns were. And, I think a lot of it, had to do with, the implementation of the schedule. We had 19 residents who presented at national meetings, and 9 who presented at the North Carolina ACP meeting, and residents had 35 abstracts at the 2019 Internal Medicine, Research Day, which is, I think absolutely wonderful. Here's some data. So I guess, this shows that, our children are learning. What this looks at is the in-training exam scores across all 3 PGY years, and it looks at the mean percentile rank, those scores. And, as you can see, really, since 2013, we've been well above, the mean. And the last couple of years, we've been right around, a mean of an 80th percentile. Again, I think it really attests to how hard our residents work, how committed they are, and, the quality of teaching, which I'll, sort of amplify in just a minute. I wanted to show, some data from the internal medicine residency. This is the annual ACGME survey that looks at, this is a survey that goes out to every resident in the United States, and, we get the results back. It's a wide range of items that residents rate. And I'll show 4 items that I think were items that we very aggressively worked on, as a department, and we weren't satisfied, with the performance. So you can see, so satisfaction with scholarly opportunities increased from 45% to 70%, which is well above the national mean. Satisfaction with feedback, greatly increased. The sense of the balance of education and clinical needs, which I think has been one of the, challenges inherent in residency programs, probably since, Tinsley Harrison roamed the halls here. So that sense of that balance, increased. And then, the residents perceived, a really significant increase in faculty's interest in, in teaching. Again, these are things collectively that we can really be incredibly proud of. And, this didn't happen by accident. We have a lot of fantastic people, in leadership roles over the past year. So, I wanted to, acknowledge Hal Atkinson, who's the residency program director, Kirsten Feiereisel, who is an associate program director, who, recently, is stepped down from that role to take on a broader institutional role. Vera Luther, who had been an associate program director, for a number of years, who also heads up our ID fellowship program. Nancy Denizard, Cindy Burns, who's the clerkship director and who was the clerkship director, and Catherine Schaefer, who formally assumed the role of clerkship director this year, but last year worked very closely with Cindy. And also like to thank, we had 8 core faculty who did amazing work. Peter Lickstein, Carl Richardson, Cindy Burns, Jeff Petty, Claudia Campos, Michelle Marks, Donna Williams, and Nasir Majid. So when we look at the data, and the improvements we saw, again, that didn't happen, by accident, and I think a lot of that credit goes to, the core faculty, the educational leadership, as well as to an amazing group of ACMs. Okay. Patient care. So I'll highlight, some data, that sort of, captures, I think, some of our key accomplishments. This is, a slide I'm also incredibly proud of. This looks at the mean CGCAP scores by section, and actually I apologize, that's FY19. And I think, what's amazing is you see really high numbers. And there were 7 sections that actually had scores that were greater, than 90%, which is, really amazing. And, includes gerontology, general internal medicine, nephrology, hemonc, cardiology, endocrinology, and ID, with several, remaining sections, very close to that, benchmark. That really, is tremendous. The other thing, in sort of recognizing faculty, so every quarter, Press Ganey puts out a list of sort of top decile performers, in their survey, nationally. So the department had, 9 faculty, who were top decile performers: Megan Alexander, Joel Brugan, Mary Lyles, Wendy Moore, Pat Ober, Fran O'Brien, Tim Pardee, Barb Pisani, and Billy Rice. And also highlight that, let's see, Megan, Mary, Wendy, and Billy have been on that list for 17 consecutive quarters, and I think Fran has been on the list for 12 consecutive quarters. Just, an amazing level of performance, and I think, dedication to patient care. And one of the, I think, really neat things that, I get to see are every week the comments from the prior week of, data collection from the patient satisfaction surveys, are sent out. It's just amazing to see, these comments, because I think they get at much more than the numbers and the kinds of things that our, patients really appreciate, and the things that our faculty do. And I'll just, again, this is, we literally get, every week, 60 to 70, of these comments. And I just picked out a couple. So this is, Bharti Upadhyaya. Dr. Upadhyaya was outstanding. Her compassion and professionalism is why we chose to drive from Cary, North Carolina, not go to, I can't make out those 2 places, to Winston-Salem. So you'll see a theme here. So this is, comment about Ray Morrow. Dr. Morrow is the best. That's why we drive 2 hours to see him. He knows what he's doing. He cares for his patients. He always gives me plenty of time and goes over all medications that I'm taking. I'm always telling family and friends what a wonderful doctor he is. And I think, we talk a lot about, marketing and, getting, the word out, but there's probably no better marketing that we can have than, having patients who, really believe, in Wake Forest and really believe in our physicians. So I think some people have heard of these things called RVUs. This, just shows for the second consecutive year we had over 1 million, RVUs as a department. We had, it was about a 6% increase between FY18 and FY19, and once again, so the department, was above budget, by about 3 to 4%, with respect to, RVU productivity. Okay, so the last area I wanted to go over is, we live in a much broader, ecosystem. And so I wanted to go over, some aspects of, the health system's financial performance, which, as we know, just has enormous bearing on all of us, and is incredibly important, with regard to investments in the academic mission, in our research, our teaching programs, as well as in the funds that we have available for, capital revitalization. So this shows, total operating revenue, over the past 5 years for the health system as a whole. As you can see, we've had, really amazing growth from 2.2 million to 3.5 billion. Some of that increase reflects the acquisition of hospitals, such as Wilkes. Probably a good chunk of that increase between FY18 and FY19, reflects the acquisition and integration of High Point, Medical Center. So revenue, is one piece of the puzzle. This then superimposes, the institutional, margin. So as you can see, we had margins of about, 39 million in FY15, 63, 75 million in FY17. The last 2 years, we essentially broke even, as a healthcare system. And it sounds great, we broke even, but breaking even doesn't provide, enough revenue to really support a lot of the programs and the reasons why, so many of our faculty are in this environment. So what are some of the key factors in the operational margin? And this will, start to highlight, I think, some of the, the stressors. It's not a volume issue. So clinical volumes in FY19 were above budget. What are some of the other factors? Well, so we have, declines in payer mix, meaning a drop in the percent of patients, with commercial insurance, and every 1% decline in commercial insurance as a payer source decreases our net margin, by about 15 to 20 million. And I want to show you some data that, this is data that was generated by Dawn Smith, who's the world's best business administrator. And this looks at the differences in reimbursement per RVU, from different, payer sources. And I think it's not necessary. So this is, expected, but I think seeing it, in I was going to say black and white, but it's more red and white, emphasizes, that, the potential impact of payer mix. So for every RVU on average we generate from a patient with commercial insurance, we get reimbursed about $112. That goes down to $61 for Medicare, $46 for Medicaid, and $6 for, self-pay. So thinking about the margin, the margin is much more, than volume, and it has a lot to do with payer mix. And the other amazing aspect about, these data is that every RVU represents the same amount of work. It's just, the reality is we get paid very differently, depending on different, payer sources. And it's one of just the absolutely crazy aspects of sort of our healthcare delivery system. So in addition to declines in payer mix, there's lots of pressures to decrease payment rates, from insurers. There's changes in policies regarding provider-based billing. So right now, many of our clinics have provider-based billing that actually yields higher reimbursement than non-provider-based billing. The challenge is that patients often see much higher copays in these types of clinics. So there's a lot of pressure, to move away from provider-based billing clinics and go to non-provider-based clinics, but that is something, that would very significantly, decrease revenues. We're seeing really significant increases in pharmaceutical and supply costs. This has had a major impact on expenditures, which, reduces margin. And then, there were some one-time costs related to the acquisition of High Point Medical Center and the opening of the Birth Center, which was, I think, has been an amazing success, to date. And right now, the Birth Center is seeing, volumes they have were, after a month in operation, were the volumes that they had projected at the end of the first year. So, but again, we live in a world of VUCA. So what else is out there? So I highlighted, so increases in insurance deductibles and copays that make provider-based, clinics, more costly, for patients. This is something, increasingly we're going to face. So how many are familiar with the Medicaid managed care program? So the state, will be essentially contracting with 5 different insurance companies, 4 major companies, and with the goal of the state is trying to de-risk their financial commitment, to the Medicaid program. It's estimated that the implementation, of Medicaid managed care will probably represent about a $30 million decrease in revenue per year. So that's, something that, is looming. Reference-based pricing by payers. So payers are saying, geez, we don't want to pay, that much for this service. So I showed you before the differences in commercial pay rates, from other payers. So many payers are saying, we're just not going to pay you as much. So everyone probably has heard about the changes that were proposed in the insurance plan for state employees, which would have, dramatically decreased, reimbursement. That was, put off, for a year, but, that we will see that, again, in the coming year. Changes in 340B pricing policies for, pharmaceuticals. Within large health systems, that care for, populations of, of large populations of Medicaid patients, we receive special prices for many, pharmaceuticals. And those prices are incredibly important to driving, margin, but there's, potentially, down the line, there's, maybe changes in the 340B pricing policies for pharmaceuticals. We had, Nancy Brown was the, chair of medicine at Vanderbilt. We had her in about a year and a half ago as a visiting professor. And Nancy said about 50% of Vanderbilt's operating margin is due to 340B pricing. And then, the entry of new potentially disruptive, providers. So we've got, the emergence of retail clinics and, CVS, Walgreens, Walmart is getting into healthcare. We're seeing, the entry of venture-backed entities in primary care and specialty care that are coming in, to the market, that I think will pose some new challenges. So these things are all part of the VUCA, that we're going to, be facing. But I think, every challenge really represents an incredible opportunity. So just wanted to highlight, what I think some of the, really key opportunities we have are. So we need to just, there are incredible institutional strengths that we really need to, capitalize on. So one is we have a growing delivery system, that's a national leader in value-based care. So last year, we received, $30 million in value-based contracts. We do really well in, with respect to value-based purchasing, which is something that's only going to get, more intensive in the future. And we're also very well positioned, to build new contracts, with Blue Cross and other commercial payers that will preferentially, send patients in value-based contracts to us. We have the pending partnership, with Atrium Health, which, again, I think everybody is hoping that this partnership and the deals will be finalized, by the end of the year. It's a very involved process. There's an incredible amount of due diligence that's being done on both sides. But, through this partnership, we'll develop a branch of the School of Medicine in Charlotte. Julie has said that there will be material investment in our academic enterprise to further grow our research and teaching programs. And I think collectively, we'll have overnight a $14 billion system that really provides the scale to thrive in an increasingly consolidated market. And I think the larger you are, the more stability there is. The second big opportunity we have, and is something I've been talking about probably ad nauseum since I've been here, is we have this incredible opportunity to lead Wake Forest's evolution as a model learning healthcare system. So I think first we just have to accept that we live in this environment that's characterized by VUCA. We also have to recognize that we have the power to drive the change that's needed to thrive in this environment, and recognize, I think this is a really poignant quote. It's actually the title of a book, "What got us here won't get us there." And I think it says that we constantly have to look at what we're doing and think about how we can build better mousetraps, because the world is not standing still. And then the most important asset we have is our creativity. And there are amazing opportunities to use our healthcare system as a lab for innovation. And I just wanted to highlight a few learning health system initiatives that represent the work of a number of faculty. Again, this is just this really sampling of a lot of the great things that are going on. And I think what these projects show is that we really want to eliminate the boundaries between research and practice, and create this incredible continuum where our health system is actually learning and improving from the research that we're doing. The first project I'll mention was the introduction of cyber rounds on 9 Ardmore, a hospital medicine unit. Was a project led by Dr. Sankara, Beekman, Dutta, and Wong. And cyber rounds involved having integrated daily rounds with a hospitalist, an APP, an RN, social worker, a navigator, and a PharmD who go to the bedside and in a very scripted way spend on average 4 to 5 minutes per patient. In the analysis that they did, they compared the outcomes in patients on the cyber unit and patients who were on control units. Similar patients but on different hospital medicine services, discharged over a 1-year period. And what they showed was a significantly lower, about a 30% lower odds ratio of 7-day readmission in patients on the cyber unit. And when they looked at 30-day readmissions, they had close to a 20% lower rate, and that value almost attained statistical significance. So again, great work that highlights research done in the context of practice that has really has important implications for the health system. Here's another project that I think highlights the potential value of our electronic health record system. This is a project that's developing the eFrailty Index, and done by Kate Callahan, Jeff Williamson, and Nick Pieski. And they've looked at this eFrailty Index in a lot of contexts. This particular project will focus on how they can use this index to improve surgical outcomes. So what the eFrailty Index is, it's a very simple tool that aggregates a wide range of data, from the electronic, health record, and it comes up with a measure of frailty, and the measure goes from, 0 to 1. So when they've looked at the predictive validity of this eFrailty Index, they found that, higher scores predicted mortality and falls and greater health care costs. So this, in this project, they'll use the eFrailty Index to identify patients at risk for, poor post-surgical outcomes. So delirium, long length of stay, poor mobility, and SNF placement, and then built around the index and identification of populations will be specific interventions to try to ameliorate, these adverse outcomes. The last project I'll mention is a project that's led by Deepak Palakshapa, Andrew Benefield, who was a resident who finished last year, Nancy Denizard and Dave Miller, using digital technologies to identify and address patients' unmet social needs. So what they've done is they've developed this tablet-based tool that allows patients to self-screen for social determinants of health prior to clinic visits, and this tool then interfaces with Wake One. It alerts providers of patients who screen positive and then generates a list of community resources in the after-visit summary. So generates a list for patients and something that, you know, patients can utilize. And this pilot project, you know, was done in DHP. And I think it's perhaps not surprising, but still striking, that almost 70% of patients at DHP who were screened reported one or more unmet social need. And what equally impressive was that 25% of patients with an unmet social need reported accessing at least one new community resource, you know, based on this, you know, very simple, you know, pilot intervention. So these are just examples of projects that we can do that are, you know, represent, you know, really, you know, implementing rigorous research into the fabric of clinical practice. And I think, you know, this can be really one of the distinguishing features of, you know, this Department of Internal Medicine. So I was hoping to save, you know, a little bit of time for, you know, questions, but I went on a little bit too long. But the last thing I want to do, so, you know, I am really fortunate that I work with, you know, closely with some very talented, you know, leadership, you know, in the department. So David Harrington, who serves as Vice Chair for Research, Hal Atkinson, Vice Chair for Education, Carl Thomas, who's Vice Chair for Faculty Development, Rudy Pasquale and Eric Summers, who serve as Vice Chairs for Ambulatory and Inpatient Care, and A.J. Durad, you know, who's Vice Chair for Informatics and Analytics. And then we have an incredible, you know, group of section chiefs that I just feel really, you know, privileged, you know, to work with across all of our 12 sections. So, anyways, I really want to, you know, thank you for your time this morning, and just, you know, thank you for everything that you do for the department. So, in the midst of VUCA, you know, I think we're doing, you know, incredibly well, and I really look forward, you know, to, you know, tackling, you know, together with everyone in this room, you know, the challenges that we'll face in the future. So, thank you very much.